every educator has encountered both types of students. Student A arrives to rounds with perfect recall. Ask them about a textbook case of myocardial infarction, and they recite the exact presentation. 62-year-old male, crushing substernal chest pain radiating to left arm, diaphoresis, troponin elevated to 2.4, ST elevation in leads 2, 3, and augmented vector foot. They know the diagnosis, the treatment, the prognosis, all memorized perfectly from practice vignettes. Student B takes longer to answer. They think through the pathophysiology. They consider how coronary artery occlusion leads to ischemia, how ischemia manifests as pain and electrical changes, why troponin rises with myocardial damage. When they reach their conclusion, they can explain the reasoning behind it. Now comes the critical test. A real patient presents with atypical symptoms. The chest pain is right-sided. The troponin is only mildly elevated. There's an unusual electrocardiogram finding. No history of hypertension, but the patient has lupus. Student A freezes. This exact vignette isn't in their mental database. The values don't match. The presentation is wrong. Student B adapts. They apply their understanding of cardiac pathophysiology to this novel presentation. They consider how autoimmune disease might affect cardiac tissue differently. They adjust their differential diagnosis based on reasoning, not rote memory. Which student would you want treating your family? More importantly, for our purposes today, which student does your hospital's artificial intelligence system resemble? What I just described isn't merely a teaching parable. It's the precise technical definition of overfitting in machine learning, translated into clinical terms we can all understand. An overfit artificial intelligence model is student A, scaled up to industrial complexity. It performs brilliantly on the exact data it memorized during training. It achieves those impressive 99% accuracy numbers that get featured in press releases and published in journals. But when it encounters real patients with their natural variations, comorbidities, and atypical presentations, it fails. The parallel is exact. The memorizing student equals an overfit model. Training vignettes equal the training data set. Real patients equal validation and test data. Inability to generalize equals poor real-world performance. Just as student A scored perfectly on written exams by memorizing specific cases, an overfit model achieves perfect training accuracy by memorizing specific patterns in its dataset, including noise, artifacts, and spurious correlations that won't exist when the model faces actual patients. How do we distinguish between student A and student B in a machine learning model? The same way we distinguish them in education. We watch how they learn. When you observe a student over time, the pattern of their learning reveals everything. Student A shows rapid mastery of specific cases, but plateaus when encountering variations. Student B shows steady improvement across diverse presentations as their conceptual understanding deepens. Machine learning models exhibit the exact same behavior, and we can visualize it through learning curves, plots that show how training accuracy and validation accuracy evolve as the model trains. An overfit model's learning curves tell a distinctive story. Training accuracy rockets upward, often hitting 99% or higher in just a few epochs. Validation accuracy lags far behind, plateauing at much lower levels or even declining. A massive gap opens between the two curves and persists or widens. The model has essentially memorized the answer key rather than learning generalizable patterns. This is algorithmic memorization. The model found shortcuts, spurious correlations, data leakage, irrelevant features that happen to correlate in the training set and exploited them ruthlessly. It looks like genius on training data. It performs like student A on real patients. A healthy model's learning curves look completely different. Both curves improve gradually over many epochs. They converge to similar final values. The gap between them remains non-zero but small and stable. Both training and validation performance plateau at sustainable levels. This is what genuine learning looks like. The model discovered patterns that actually generalized to new data. It learned the equivalent of pathophysiology, not just answer keys. Before trusting any medical artificial intelligence system, demand to see these curves. If the developers cannot or will not show you evidence of healthy training dynamics, walk away. High final accuracy means nothing if it was achieved through memorization. Let's return to our students and follow them into clinical practice, because this is where the consequences become visceral. Student A graduates. They scored 99% on their board exams, which tested primarily on standardized vignettes. They enter residency with confidence and impressive credentials. Then reality intrudes. A patient presents with chest pain that doesn't match the textbook description. Student A orders tests but misses critical signs that don't fit the memorized pattern. An elderly patient with multiple comorbidities has overlapping symptoms. Student A, trained on clean, single diagnosis cases, struggles to integrate the complexity. A time-sensitive condition requires immediate pattern recognition. Student A hesitates, searching their mental database for an exact match that doesn't exist. The outcomes? Delayed diagnoses, missed interventions, inappropriate treatments, patient harm. Now scale this to thousands of patients, and you have an overfit artificial intelligence system deployed in clinical practice. The model that achieved 99% accuracy in development shows a sudden, dramatic performance drop. Accuracy falls to 70 to 80% on real patient data, or worse. Sensitivity plummets, missing rare but critical conditions. False confidence leads clinicians to trust incorrect predictions. Diagnostic errors cascade through patient care. The gap between development performance and deployment performance isn't a minor technical detail. It represents real patients receiving wrong diagnoses, delayed treatments, and potentially irreversible harm, all because an artificial intelligence system memorized training data instead of learning medicine. Understanding why models overfit requires looking at the conditions that enable memorization, both in students and in algorithms. Memorization flourishes when students study only practice questions, never encountering real case variations. They focus on answers rather than understanding mechanisms. They're never tested on truly novel scenarios that require reasoning. There's no feedback loop that exposes the limitations of memorization. The reward structure, grades, and rankings prioritizes getting answers right over demonstrating understanding. Overfitting occurs through parallel mechanisms. Data leakage, meaning the model has access to features that essentially give away the answer, like including current weight when predicting future obesity risk, or including medications when predicting the conditions they treat. Spurious correlations, meaning the training data contains patterns that work perfectly in development but don't reflect real clinical relationships, like learning that specific hospital protocols correlate with diagnoses rather than learning the actual disease signatures. Inadequate validation, meaning the model is tested only on data from the same source, time period, or patient population as training data, allowing it to memorize institution-specific quirks. Shortcut features, meaning the dataset includes variables that act as proxies for the diagnosis, rather than genuine risk factors, like specialist referral patterns that only occur after a condition is suspected. The fundamental problem is identical in both cases. The learner found an easier path to high performance than actually understanding the subject matter. Just as experienced educators can spot a memorizing student before they fail in clinical practice, we can detect overfitting in artificial intelligence models before deployment disasters occur. Perfect recall on seen cases, but panic when presented with variations. Can recite facts verbatim, but cannot explain reasoning. Struggles with what-if questions that require applying knowledge in new ways. Rigid thinking that cannot adapt to atypical presentations. Confidence that exceeds competence. Certain about answers, even when wrong. The parallel indicators in machine learning, training and validation curves diverge significantly rather than tracking together. Accuracy spikes rapidly to near-perfect levels in early epochs. Performance drops dramatically when tested on external datasets. Cannot explain which features drive predictions in interpretable ways. relies on shortcut variables rather than clinically meaningful patterns. Unstable validation performance that fluctuates wildly during training. Developers cannot or will not show training dynamics when asked. These warning signs should be deal breakers. If you're evaluating an artificial intelligence system for clinical adoption, and the developers cannot demonstrate healthy training dynamics with converging, stable curves, the system is not ready, regardless of the final accuracy number they report. The path forward requires fundamental changes in how we approach both medical education and artificial intelligence development, guided by the same principle: reward understanding, not memorization. Effective clinical education requires teaching pathophysiology and mechanisms, not just diagnosis answer pairs, exposing students to wide variation in how conditions present, testing reasoning ability, not just recall, providing real patient exposure where textbook presentations are rare, encouraging explanation and thinking aloud to reveal understanding, creating assessment systems that cannot be gamed through memorization. Reliable artificial intelligence systems require parallel rigor, eliminate data leakage, conduct systematic audits of every feature to ensure it represents information that would actually be available at the moment of clinical prediction. Remove anything that encodes the answer, results from the diagnosis, or serves as a proxy. Implement proper patient-level splits. Data from the same patient must never appear in both training and validation sets. The model must learn to generalize across patients, not memorize individual patient patterns. Monitor training dynamics continuously. Track and visualize how both training and validation accuracy evolve. Stop training when validation performance plateaus, not when training performance maximizes. Validate on truly external data sets. Test on data from different hospitals, time periods, patient populations, and geographic regions. Performance on the same institution's data proves nothing about generalization. Address class imbalance properly. In medical data where disease is rare, accuracy is meaningless. Demand sensitivity, specificity, precision recall curves, and confusion matrices with absolute counts. Demand interpretability. The model should be able to indicate which features drive its predictions. If it cannot, you cannot verify it's learning clinical patterns rather than artifacts. Before allowing any artificial intelligence system to influence patient care in your institution, demand satisfactory answers to these 5 questions. Question 1. Was data split at the patient level? Random splitting of rows means the model trains on some visits from a patient and tests on other visits from the same patient. This allows memorization of patient-specific patterns rather than learning disease patterns. Proper splitting ensures no patient appears in both training and test sets. Question 2. Were leaky features identified and removed? Every feature must be audited. Would this information actually be available at the moment we need to make this prediction in clinical practice? Features that encode the outcome, result from the diagnosis, or serve as proxies for the condition must be excluded, even if they boost accuracy. Question 3. What do the training curves show? Demand to see plots of training and validation accuracy across all epochs. They should show gradual, stable improvement with convergence. Rapid jumps, large persistent gaps, or unstable fluctuation indicates memorization, not learning. Question 4. How was class imbalance handled? For rare conditions, overall accuracy is useless. You need sensitivity. Does it catch actual disease cases, precision recall curves, and confusion matrices showing absolute counts of true positives, true negatives, and false negatives? Question 5. Was there external validation? Performance on held out data from the same institution, time period, and population is insufficient. The model must prove it generalizes to truly independent external data sets from different sources. If it hasn't been tested externally, it hasn't been validated. If developers cannot answer these questions satisfactorily, the system is not ready for clinical use, no matter how impressive the accuracy claims in their marketing materials. Here's where overfitting intersects with another critical problem in medical artificial intelligence: the accuracy paradox. Consider a dataset where 95% of patients are healthy and 5% have disease. A model can achieve 95% accuracy by doing absolutely nothing useful, simply predicting healthy for everyone. Every healthy patient is correctly classified. Every sick patient is incorrectly told they're fine. Now imagine an overfit model trained on this imbalanced dataset. It memorizes patterns that happen to correlate with healthy in the training data, maybe certain hospital protocols, specific combinations of features, demographic characteristics that appeared more often in healthy patients. The result? 99% accuracy with 0% sensitivity. It looks spectacular in a press release if they mention the accuracy value only. It's completely useless, worse than useless, in clinical practice, because it creates false confidence while missing every disease case. In medicine, missing the disease is the worst possible outcome. High accuracy without sensitivity is clinical failure dressed in impressive statistics. The proliferation of overfit artificial intelligence systems in medicine is not a developer problem or a data science problem. It's a healthcare problem that requires active participation from medical professionals. When vendors present artificial intelligence systems with 99% accuracy claims, your immediate response should be, show me the training curves, show me the confusion matrix. What's the sensitivity? Was this validated externally on truly independent data? High accuracy numbers mean nothing without context. They can represent genuine performance or sophisticated memorization. Your responsibility is to know the difference. Artificial intelligence systems that will influence patient care must be held to rigorous standards. Developers should willingly and clearly show complete training dynamics with conversion curves, detailed confusion matrices with absolute counts, sensitivity and specificity for all relevant conditions, evidence of external validation on independent data, feature importance and interpretability evidence, and documentation of how data leakage was prevented. If they cannot or will not provide this information, they're asking you to trust them blindly with your patient's well-being. That is not acceptable. Medical professionals must engage in artificial intelligence development, not just artificial intelligence adoption. Your clinical expertise is essential for identifying which features could represent data leakage, determining appropriate patient-level data splits, recognizing when metrics don't reflect clinical priorities, spotting when results seem too good to be true, they probably are, and translating performance metrics into real-world consequences. Without clinician involvement, even sophisticated artificial intelligence systems will miss critical clinical nuances and fail in ways that developers cannot anticipate. Medical education must evolve to prepare clinicians for an artificial intelligence augmented practice environment. Every physician should understand the difference between accuracy and sensitivity, how training dynamics reveal memorization versus learning, what data leakage is and why it's disastrous, how to read a confusion matrix, why external validation is non-negotiable, and when to trust artificial intelligence and when to question it. This doesn't require turning doctors into data scientists. It requires teaching critical evaluation frameworks that allow clinicians to ask the right questions and recognize inadequate answers. The future of medical artificial intelligence depends on deep, sustained collaboration between clinicians and developers, not vendors selling black boxes, but true partnerships where both sides contribute essential expertise. Developers bring technical knowledge of algorithms, optimization, and evaluation frameworks. Clinicians bring understanding of workflows, clinical priorities, and real-world consequences. Neither side alone can build safe, effective, artificial intelligence systems. This collaboration must happen at every stage. Data collection. Clinicians identify what information is actually available at the moment of decision. Feature selection. Clinicians spot potential leakage that developers might miss. Model evaluation. Clinicians interpret whether metrics reflect meaningful clinical value. Deployment planning. Clinicians determine how artificial intelligence integrates into existing workflows. Ongoing monitoring. Clinicians detect when performance degradation affects patient care. The days of developers working in isolation, then presenting finished artificial intelligence systems to clinicians for passive adoption, must end. The stakes are too high for that approach. We return to where we began: 2 students, 2 approaches to learning, and a fundamental question about what constitutes competence. Student A, the memorizer, achieves perfect scores on standardized tests. Their recall is flawless. Their confidence is high. But when faced with real patients exhibiting natural variation, they struggle. Their knowledge is brittle. Their understanding is shallow. Their clinical value is limited. Student B, the understander, might score slightly lower on standardized exams. Their answers take longer. They need to think things through. But when faced with atypical presentations, they adapt. They reason. They generalize their knowledge to new situations. They become the clinician you want managing complex, ambiguous cases. The same distinction defines the difference between overfit artificial intelligence models and robust ones. An overfit model achieves spectacular accuracy on training data by memorizing specific patterns, shortcuts, and artifacts. It looks brilliant in development. It fails in deployment. It creates false confidence that leads to diagnostic errors and patient harm. A well-trained model achieves sustainable accuracy by learning genuine clinical patterns that generalize to new patients, new institutions, new time periods. It learns pathophysiology, not answer keys. It adapts to variation, doesn't freeze when encountering novel presentations. Real medicine requires the ability to adapt and generalize to the variations every patient brings. That applies equally to human learners and artificial intelligence systems. As artificial intelligence becomes increasingly integrated into healthcare, we face a choice: accept impressive-sounding accuracy claims at face value, or demand the rigor required to distinguish genuine competence from sophisticated memorization. The choice we make will determine whether artificial intelligence amplifies medical expertise or amplifies errors, whether it improves patient outcomes or creates new categories of harm, whether it serves as a valuable tool or a dangerous liability. Memorization and understanding may both produce correct answers on standardized tests, but only understanding sustains performance when the test looks different than expected. And in medicine, every real patient is a test that looks different than expected. This episode brings together findings from almost 40 peer-reviewed studies conducted and published by our exceptional students and myself. These research efforts ultimately culminated in my authorship of 2 books on medical artificial intelligence: Diagnosing AI and AI-Assisted Medical Diagnostics. My name is Dr. Toma, and I serve as an associate professor of algorithmic medicine at the New York Institute of Technology College of Osteopathic Medicine. For detailed frameworks, evaluation checklists, and practical guidance on implementing safe medical artificial intelligence, please refer to my books.